Okay, brilliant. Thank you very much, Andrew. I think your talk actually was very useful to listen to and leads quite nicely onto a few concepts that I'll be talking about today. So I'm Parisa Zarringhalam. I'm one of the medical affairs consultants at a company called Open Medical, and I'm joined here by my colleague Zach from the company and one of our partner organisations, which is Lancashire and South Cumbria ICB. We have Kaye Davies, who's a senior programme manager, and she'll be talking about a project that we're doing there at the moment as well. Medical affairs consultant is one of the most vague and broad role descriptions in industry, but essentially I am a clinician. I worked as a maxillofacial surgeon in the NHS for many years, so I'm very familiar with patient care pathways in both primary and secondary care, and now I lead on our oncology work, so I'm concerned with how digital tools or our digital tool can be applied in real healthcare settings, but also looking at the market, speaking to stakeholders and seeing what the current needs are. I also work for Macmillan Cancer Support in a strategy role, which is looking at early cancer diagnosis and the role of health inequalities in different populations. So, as you've probably guessed by now, our talk today is focused on oncology, and we're going to be focusing our case study on an ICB level implementation in oncology. So as a company, we are primarily a digital health company founded by a former and actually in fact current NHS surgeon, and we have a software solution called PathPoint, which is a workflow optimization solution that we've implemented in many sites around the NHS. But the main bit of activity that comes out of our company is actually the sort of consultancy and pathway optimization work. So every one of our projects really is a collaborative effort between us and the stakeholders, looking at what the current pathways look like, what are the challenges and pain points, and designing a solution that tackles those pain points and using our experience in the industry to advise our clients. We are currently operational in over 180 NHS and HSE sites, processing over 4 million patient pathways. And as you can see in this pretty diagram on the right, our solution is disease agnostic, so we operate across a range of specialties, our flagship specialty being surgery, but more recently we have extended our work into oncology pathways, and you'll see through some examples. So just bringing the conversation round to cancer, really I just wanted to bring everyone back to the high-level strategy that currently is in place in the UK. Obviously, with the election outcomes, this may change. We don't know how. But the key targets in our country at the moment are to diagnose cancers earlier, and the target is to diagnose 75% of cancers at early stage, i.e. stage 1 and 2, by 2028. But there are also other targets to improve 5-year survival in the majority of patients, improve quality of life outcomes, patient experience of their care, reduce health inequalities, and reduce the variations in care. Now, these are all hugely complex, hugely challenging sort of strategic priorities, and as a digital health company, we contribute to the bits that we can, and I'll talk a little bit about that in a moment. So lots of ICBs are looking at digital health solutions, and lots of tools are being utilised, as I'm sure most of you will be familiar with one or two or many of them. But a large number of them will sit within that central circle in my diagram, which is cancer management systems. So this largely consists of workflow solutions, that's your referral management, MDT platforms, PROMs, patient engagement, appointment scheduling, and all of those sort of tools. And then you've got your registries, which collect that really critical data that we need from cancer care pathways for the national registries that the National Disease Registration Service deals with, and to look at sort of our strategic priorities using that data. Outside of that, there are many other tools being used, like BI tools. Now, typically business intelligence tools in the NHS are used for operational reasons. They're not used so much in day-to-day clinical care. And then you've got the AI tools, which could be a talk in itself, and that's not my area of expertise, so I won't be going into that today. And of course, we're now utilising more and more clinical decision support tools, which sits more at the clinical end of digital in oncology care. And really, we have to ask the question of why we are adopting more and more digital technology in cancer care. Now, here I've just put some of the challenges that we're being asked to tackle within the NHS. So typically, digital was used to improve collaboration, help with earlier diagnosis of cancers, collecting high-quality data, helping to improve decision cycles, so things like your MDTs and your referral management software, but also for governance and managing and ensuring regulatory standards are met. But increasingly, we're seeing a change towards more benchmarking and best practice activities, looking at improving efficiency in cancer pathways, new things being introduced like genetic screening and new surveillance programs. And there's a huge call for having more patient engagement in their healthcare and in the pathways. Aside from that, we know that the NHS wants to improve personalised medicine and holistic care delivery, and we'll talk a little bit about that and how that's potentially going to be delivered. But also things like protocolized MDTs. We know that MDTs create a bottleneck for many cancer pathways and services. And actually, can we look at protocolized MDTs using digital tools to get these patients who coming out with well-known diagnoses and have well-defined treatment protocols to essentially skip that bottleneck? And increasingly, we are being required to offer real-time reporting, both for operational and clinical use, although on the clinical side, we're not really doing that so well yet. And all of this will come under that digital transformation umbrella, but it's really a lot of requirements being put on ICBs now to meet all of these things, whilst we've got this ongoing issue of resource limitation that we know post-Brexit has become worse and worse in this country. So how do we meet these demands? How do we manage all of these requirements, amongst the many that I probably haven't even mentioned in this talk today? So this is actually a diagram that we use at the company, and it shows a range of services that we can provide to trust or ICBs. And on the other end, if you're working for an ICB, as my colleague Kaye does here, you're looking at these options and you're probably thinking, where is best to put our funding, where is best to put our resources, our project management skills. And that really depends on your areas of need. So there's no one-size-fits-all digital tool that's going to tackle challenges from ICB to ICB, sometimes even from trust to trust. And there's no specific sort of patient population factors that we've pinned down to responding to a particular digital tool, because we just don't have that level of data yet. So really it's about consulting with the providers and looking at what your areas of need are, having access to high quality data to then move on to that procurement stage where you use these different tools. On the other hand, we as a digital health company have formed our own strategy around oncology digital tools. So I mentioned in my first slide that we are a company that focuses on transformation first and digital second. Now, we have the luxury of having a very customizable and pathway agnostic platform where we can build specific platforms for specific use cases. But really, the piece here is understanding what the local need is and trying to meet that need. Within the company, we've focused our oncology strategy around 4 key areas. And the first one would be early detection. Now, this sounds like we're just kind of repeating what the NHS long-term plan for cancer is, but really, digital tools play a really, really important role in efficiency. And where that really plays out is that patient referral to decision-making aspect. So you can digitize a significant part of that pathway, particularly when it comes to straight-to-test pathways, to get patients to that point of diagnosis a lot quicker. In the MDT world, our MDT processes in the NHS are still very fragmented, very archaic, very paper-based, and they rely on individuals being present at a set time and place to discuss cases. Often they're overburdened with too many cases, so if your name happens to be further down at the bottom of the list, you're probably going to get less time in your discussion than if you're first on the list. And what we need to try and move towards is more asynchronous multidisciplinary team management. What does that mean? Is that you have a central source of truth with visibility to all the stakeholders, but you and I don't need to be sat in the same room at the same time to coordinate this patient's care and or delay this patient's care. And really what we need is that time where you are all sat in a room together or virtually together is reserved for those patients who are highly complex and need longer discussion times rather than every single case. And risk stratification is an obvious one where obviously having high quality data will allow you to flag up the more high risk cases early on. In terms of integrated cancer care, when you have digital solutions that can allow teams to communicate across organizational boundaries, particularly important in ICB level procurement, then you can enable that true collaboration and resource sharing between regions as well. This has some additional benefits in terms of offering flexibility of working for healthcare staff. We know that the NHS workforce is burnt out, they're struggling. Traditional roles are now not as appealing to the younger generations, and this concept of flexible working and resource sharing is going to become more and more important in the years to come. With regards to health inequalities, now as a digital health provider, we don't claim to help with health inequalities, but certainly what is at the forefront of our focus is not widening health inequalities due to digital exclusion and trying to improve access through some of our digital tools. So, for example, in one of our platforms that's used for teledermatology, we know from having done patient and public involvement and engagement activities that, for example, in geographically spread communities, it improves access to care, reduces the need for travel, and reduces the need for time off work. So things like this are very important to us, and examining the impact our platform has on societies is incredibly important. And last but not least, real-world evidence. Now, a lot of our cancer pathways are captured on different systems. A lot of the data still sits in paper, MDT being a big one. And we need to move towards systems where all this data is being captured real time and on a central system so that we don't just submit it to national registries because we have to, but we're actually using that data in real time for clinical decision making and operational management. So we undertook a big exercise this year where we did lots of stakeholder engagement sessions looking at what people need in cancer. And I apologize, this is a busy slide, but I almost didn't want to take out at many of the points because I think they are all really, really important. So what do the clinicians want? Clinicians want visibility of patient data. They want to be able to identify and prioritize their high-risk cases earlier, rather than waiting for the patient to turn up to clinic to realise that they've deteriorated. They want to be able to make evidence-based decisions and improve communication in the multidisciplinary team. They want to track their patients' outcomes remotely, have a bit more flexibility in their work, and have real-time insights through access to real-time data. And one thing that kept coming up is they want all of this, but they still want to do less, not more, because they are busy. What do patients want? Patients want more personalised and holistic care. Now, recently we've been talking a lot about holistic needs assessment in cancer, personalised care delivery in cancer, but still a long way away from having truly personalised care in the NHS. They want to be engaged and feel empowered in their journey. They want easier access to their clinical teams. They want decisions to be made faster and be regularly updated. And one quote I heard from a patient is that, waiting 28 days for a diagnosis, to us, that's the faster diagnostic standard, but to a patient, 28 days is a very, very long time. And I have personal experience of this with a family member. Every day that you wait is another day of trauma for the family. Cancer coordinators and managers, what do they want? They want reduced administration, more use of intelligent automations. They want a single source of truth because they spend a large part of their time chasing clinicians, chasing managers, exchanging emails and telephone calls. They want standardized reporting and live tracking of the patient list. And ultimately, they want less meetings, emails and paper, and more tools to actually let them do their work. And from a senior management perspective, they crave improved insight. They want to be able to integrate care across organisations and teams. They want to improve capacity and performance, of course, and standardise the care delivery across regions. And one thing that's really going to allow them to do that is having a real-time reporting engine and KPI analytics. So they're tasked with increasing their productivity and match that demand with a reduced workforce, which is no easy feat. Now, it's worth talking about patient engagement a little bit here, because I think this is an area we've certainly noticed that more and more ICBs are showing an interest in the utilisation of PROMs, digital holistic needs assessments and personalised care plans in cancer. I think we're probably on the cusp of change with that. We are a PROM supplier and accredited by the NHS and FIN in the private sector. We have yet to implement a PROM solution in oncology, but I think over the next couple of years that's going to become much more prevalent. And PROMs is one thing, but remote monitoring is probably going to be the arguably more important utilisation of patient engagement. With the increasing number of complex oncology drugs getting licensed in the UK and being approved by NICE, clinical teams are tasked with actually delivering these drugs and monitoring them, and it's not going to be currently met with the current workforce that we have. So using remote monitoring for drug management is going to become really, really key over the next year or so, I think. And I just wanted to draw everyone's attention to this concept of value-based healthcare, because we don't really talk about it enough, I think, in the NHS setting. But really what we're aiming for is, at the end of the day, high-quality, patient-centred care. And with that, in cancer, I think there are 4 key areas. There's the area of prevention. So we can use digital tools, we can use modern tools to do things like case finding from primary care records. We can digitize surveillance programs. Now, there are increasing numbers of surveillance programs being talked about and implemented in the NHS, such as Lynch syndrome being one of the newer ones. And again, they're very resource intensive to keep track of so many patients, hundreds of patients, thousands, if not, in a region is going to be very, very resource intensive, and we have to turn to digital tools to do that safely. But also, it can be utilised for things like patient education and engagement with a public health goal on. Now, in terms of holistic care, we've talked a little bit about PROMs and patient-reported experience measures and remote monitoring, but also shared decision-making can happen through digital tools that at least alert clinical teams to what the patient's reasonable adjustment needs and particular needs are with their care prior to any decisions being made. With regards to early diagnosis, I've kind of touched on this already, using digital use to streamlined referral and triage pathways, optimized straight-to-test pathways through digital tools, but also things like adopting community care sites such as CDCs into those digital workflows can happen as well. And last but not least, looking at real-world evidence. I think having that real-time data to look at the outcomes, look at things like health inequalities, is going to be really key in delivering value-based healthcare in oncology. So I'm going to tell you a little bit about our project in Lancashire and South Cumbria, and I'll hand over to Kaye before we do a short panel session. So we have a teledermatology platform called eDerma, and this platform has been established to connect regional skin cancer pathways and improve the clinical workflow in skin cancer detection. So it will be no mystery to most of you that skin cancer is a huge problem in the UK. It's one of the most highly referred suspected cancers, or second one in fact. And it has a very low conversion rate, so the majority of patients will not be diagnosed with cancer after referral. However, they continue to take up a large part of dermatology workload, and we have a shortage of dermatologists in this country. So the numbers don't really add up, and many regions are now already using teledermatology solutions, and we're going to share one of our projects with you. Our platform looks, the workflow of our platform looks a little bit like this. I apologize, it's a bit of a confusing diagram, but it's confusing for a reason, in that we allow clinical teams to use the clinical resources and pathways that suit their needs, sometimes even multiple models of care within one region to deliver the care to patients. So while some communities will take a referral from a GP, supplement that with our patient questionnaire that reports further information about the patient's concerns or their lesion, and then the patient will be referred to a locally approved site for a dermoscopy image, which is essential in diagnosis or exclusion of skin cancers in this country. So that can sit in primary care at a GP surgery, or it can sit in a CDC site, It can be in a hospital, in a dermatology department, usually by a allied health professional or a medical photographer in hospital. And whatever the local setup and resources are, we can accommodate that onto the platform, and that's where the flexibility is really important. All of these bits of information and data then feed into a consultant triage facet on the platform that allows consultants to safely diagnose in some cases, but also plan further management. Now, in fact, the majority of patients at this point will be discharged, and we found that across most of our platforms, over 95% of patients are triaged within 48 hours. So the patients that then, for example, require face-to-face follow-up or straight to diagnosis, such as straight to biopsy or surgery, then end up getting their treatment plan a lot earlier and their diagnosis or exclusion of cancer a lot earlier, which is incredibly valuable. In Lancashire and South Cumbria, we joined forces towards the end of last year to deliver an ICB-wide skin cancer solution. And this includes 4 NHS trusts and a primary care network. And what's different and unique about this project, both for us and the ICB, is that we're using a centralised virtual triage model. So all referrals for skin cancer will go to a centralised pool and be triaged by a cohort of very experienced and competent dermatology nurses to then be allocated to the correct regional unit. And I'm now going to hand over to Kaye, who's going to tell us a little bit about this project.
Hello, so I'm Kaye Davies. I'm from Lancashire and South Cumbria ICB, specifically the Cancer Alliance. So most of you all know the Cancer Alliance is generally part of the ICB, and we're sort of the operational arm of delivering the long-term plan aspirations for cancer, which is early diagnosis, faster diagnosis, innovation, everything from screening to improved treatments and everything in between. My team look after faster diagnosis, or I'm part of that team. So we're specifically looking at how we improve the 28-day standard, but there's a lot more around that, obviously. One of the areas my team covers is skin cancer, and this is our specific problem in Lancashire and South Cumbria. So what you just shared is great for the national picture, but for us it's a lot worse, in fact. 23,000 referrals last year, that's going up 8% year on year. So this year we've got a lot more. We have a really high number of inappropriate referrals. So whilst the national standard is under 20, in Lancashire and South Cumbria for June 24, it was 2.21%. That means more than 97% of patients that come through on our pathways are inappropriate for that pathway. And when I say inappropriate, obviously a patient's got a concern about a skin lesion, the GP's got a concern about cancer, but actually most of those patients will be discharged either back to GP, into our community dermatology services, which look after low-level BCCs and skin lesions that can be treated, or they end up on an urgent pathway in trust, and 2% of them will stay with us on an urgent suspected cancer pathway. So the front end, the front door of our pathways is absolutely flooded. We have a depleted dermatology workforce. Interesting to see that there's 626 nationally. I think I might have 8 in Lancashire and South Cumbria. And that's a big problem for us. Recruiting to that workforce as well, and making sure that trusts prioritise that recruitment to those posts is really tricky, because you can see there on the graph, that's each of our trusts represented in terms of referral numbers, and there is a seasonal variation, a significant one, because when you're wearing less clothes in summer, you're more likely to find your skin lesion. So we tend to find that each year we get a height around September, October, and then it drops off again. So for a trust to say, go on, I'll hire a permanent member of staff to help at the front end, that's even harder to justify in an already under-resourced area. The bottom 2 bullet points there refer to what our previous teledermatology approach looked like. We had different providers, 4 different trusts doing different things. Some had telederm, some didn't believe in telederm, somebody else, Morecambe Bay, wanted artificial intelligence straight out the gate. So everybody's working with a different mindset, each of those trusts, not to mention primary care, who also want a different solution for them. So we needed to really come up with something that would address this regionally. Now, I'm sure you can imagine the challenges in that. The bottom point is just a nod, really, to... It's great that cancer pathways are prioritised, right? It's absolutely right that they should be. Well, that means for you, if you're on a routine or urgent pathway, because you've got something that needs some topical cream and that you need to see a consultant about because it's not on the GP formulary, you can't get there. In Lancashire, South Cumbria, our waiting lists are 18 months or more for that. And that's because we're having to prioritise cancer, and all of those referrals means that the depleted dermatology workforce I've got are going to prioritise cancer over those things. So the knock-on effect for the system is particularly broad. Okay, so this is what we came up with. Parisa's already given you sort of the flavour of where Pathpoint eDerma fits into this, but this is where we're headed now, and we're about, I'd say we're probably about 60% of the way to delivering this, and I'm looking to commission it 25, 26. So bear with me, here comes the story. You ring up your GP, you found a skin lesion on your skin. As soon as you contact your GP, the receptionist is going to ask you 6 to 8 questions, and basically that's just to determine if you could be right to come on one of our teledermatology pathways. Assuming that you are, you get sent to our skin hub. That's run by a PCN. The idea is that will actually be accessible to all GP practices across Lancashire and South Cumbria. The skin hub then, I'm now on sort of the second row down, the skin hub will call you as a patient, and they're going to ask you 20 questions. They're going to make sure that you're all right to have an image taken of your skin lesion. Is it in a hairy spot? Is it where a tattoo is? Is it in an area that can't be photographed, sort of in your genitalia line, that sort of thing? And that's determined. If you are suitable, then the next one down is you're going to come to a local skin hub image capture service. That's based in primary care. We've got 3 of them at the moment in one sort of place area within our ICB, and I intend to have 10 commissioned. That's what I'm going in for, 25, 26. So as a patient, you found the skin lesion, and generally, this is up and running now, generally you get to have your picture taken of that lesion within 4 to 7 days. And I'm talking now, sort of in September, which is at the height. Now, what would happen previously is that you'd have found that skin lesion, you'd have waited 3 weeks to see a GP, GP would have eyeballed it, put you on a skin cancer pathway, they'd have seen you face to face, so you're 5 weeks deep before you've even seen anybody. And we can speed that up now, closer to a patient's home. The picture's taken, and then we get eDerma does its wondrous thing and transfers it to our centralised virtual triage team. As a team of dermatologists that don't necessarily work in Lancashire and South Cumbria, they can work virtually. So I can grow that dermatology workforce, by sort of picking the pocket of other ICBs up and down the country, and they can triage wherever they need to, and crucially I can flex that workforce so I can have more of them in September, October, and fewer of them in February. They triage on the Pathpoint eDerma platform, and from that triage the options are at the bottom there for the decisions they make. So they make these decisions to either discharge, to sort of back to the patient, discharge to the GP with advice to prescribe Effidix or something else, send into our community derm services, or crucially, put on an urgent suspected cancer pathway. This model is in place and has been in exactly that form for some time, and we're seeing about 50% of patients sort of the latter 3 options, not on a cancer pathway. But crucially, the patients, no one's said cancer to the patient yet. They're not in secondary care yet. And when they do land in secondary care, they come with pictures, triage notes, a recommendation for bring this patient in for a biopsy or a minor excision, and that could be booked straight away. So that's where we're headed. The benefits are on the other side there. The system saving, which I'm least concerned about, is the projected savings, which we've obviously done the workup for, which is positive. But this has got benefits for primary care because we're repurposing those GP appointments that are under, you know yourself, you ring the GP, you've got 2 to 3 weeks before you can actually get in. So that's really beneficial to primary care, and obviously the benefits of secondary care are evident. I'm going to pause there because I'm talking at 1,000,000 miles an hour. Right, okay. Challenges. I'm sure I'm preaching to the choir. The cross-system working involved in this, across 4 well-established trusts, and all of primary care are complex. And just the second bullet point, that even just to procure a system where everybody more or less agrees has been challenging. And I think we're about 2 years deep now from when we first started conversations. Is that about right? So to get to that point has been hard for. We've had to fund the central virtual triage workforce because I can't ask one trust to pay for that. It's got to work for everybody, including primary care. So the Cancer Alliance, the ICB, has stood up the funding for that. Trying to commission it while our ICB hasn't got any money at the moment, so that's going to be a trouble anyway. So I might end up funding this for a lot longer. And then the bottom one there is about where does AI feature in this? And we've been quite lucky in that in Lancashire, South Cumbria, we've looked at AI pre-referral, with primary care using it, and secondary, and sort of post-referral, once a patient's on a secondary care pathway, and had a picture taken in secondary care. Jury's out on whether that works for us. But that being said, we have designed a model whereby we think we can plug AI in for 25, 26. And like you were saying, Parisa, eDerma is agnostic, so we can to what AI platform it uses. So we're at the table now in conversation, aren't we, around what we want that to look like for Lancashire and South Cumbria. And I think we're going to use AI as a safety net before we discharge a patient. So if our clinician says, oh yeah, this definitely goes back to GP, I want the AI to check that and then send on. And that seems to be the direction of travel we're going in, whereas other areas are using AI as a triaging, making decisions for biopsy and excision route, which hasn't gone down well with our clinicians. So that's that. Where are we at? From that model that I showed, the pathway, you can see from this chart, this is the rate of telederm versus skin cancer referrals per 1,000 GP population. I've not got that many GPs using it at the moment. It's optional. There are 54 GP practices that can use the skin hub and have a picture taken there. But you can see a correlation between, so if we look at Withnail Health Centre at the top there, the more telederm they've done, up to 40, the fewer urgent suspected skin cancer referrals there are. And that seems to blend true out of some of the initial data. Obviously, this is up to May 24, and it's gathered a lot more momentum since, with more GPs coming on. So we're keeping an eye on that. Well, it seems to make sense. We've been doing it for a year, and the data coming out of it now is more reliable. It's quite hard to prove because our referral numbers have gone up anyway. GPs can opt in or out of this service, so that's proving a challenge. We get great feedback from patients from the Skin Hub because they're getting a picture taken quickly at their local GP, and no one said the word cancer to them until they are on a cancer pathway, and when they are, they're referred quickly. We're also making sure this offers us, that central virtual triage team offers us a lot more control over the outcomes for patients. So where previously one trust would be sending some patients to community dermatology for the treatment of an AK or a low-level BCC, basal cell carcinoma, some would send them there and others would hang on to them. So one trust would send to that service, which we pay for as an ICB, and the other would hang on to them and put them on their urgent and routine pathways, which is adding to me 18-month waiting list. So now, because central virtual triage are making those decisions, I can make sure that the specification that would mean that all those sorts of patients would go to the community derm provider can be applied. So it gives us a lot more consistency. It gives us a lot more consistency in terms of clinical letters that are issued, information that patients are getting, so that someone in Fleetwood or Blackpool is getting the same information as someone in South Cumbria and Lancaster. And that's really beneficial and something that we haven't really been able to get to before. So I think that's the story of where we're up to right now. Our next steps are, we've probably got another year ahead of us to actually achieve that. And I hope that's been useful. So thank you. I'm handing over to you, Zach, right now. Or?
I think in the interest of time, probably not
okay.
Time. But if any quick questions for the very patient audience, that'd be great.
So I just have one question.
Yes, of course.
With the Oncology, how were the patients getting their responses if they're not being referred to the two-way pathway? Is it messaging? Is it a clinician calling them?
Yeah, at the beginning of the pathway, the patient answers the questionnaire that Parisa was sort of, which is question about the skin lesion, but also do they consent to email confirmation of the outcome. And then when the central virtual triage team makes that decision, we can email that to them, or there is a sort of catch-all process to print that and put it in an envelope. Yeah.
Then does it get uploaded into the patient's notes?
Yes, yeah, it does. Yeah, that goes via an integration with each of the trusts that then can make its way to GP as well. Yeah.
You've said it's about 1.2 million in savings in the first year. I was wondering if you were able to share what the costs or what the investment was relative to the savings generated.
Yeah, I think so. I can do that, right?
Yes.
Yeah.
Maybe a question offline.
I can tell you what the central virtual triage team has cost us in terms of the money that has been in my gift around digital. I don't know what I'm allowed to say or not. So the central virtual triage team has probably cost us about 250 grand over 2 years. And that's stood up by a couple of substantive staff, probably going through 12 to 15 images an hour, one after the other on the system. And then we have bank staff to flex for the seasonal variation. And then there was a pot of money to purchase eDerma, which I'll let you talk to Zach about.
Yes.
Thank you so such a great presentation. I just wanted to know, me myself being from a PhD therapist background. So in your triaging, you're aiming early diagnostics, but in the delivery of or implementation of the treatment or management, is there a triaging there also at some point to direct them for rehab at some point?
So I think your question is when a triager has outcomed a patient and decided actually this patient needs to be on your cancer pathway or needs to be on your urgent pathway, and can you biopsy them or minor excision them or bring them in for a face-to-face? That's what you're asking me, whether that's re-triaged at that point. Ideally, I don't want it to be. Because and that's part of the challenge here, in that I can't get a lot of the consultants across the 4 trusts to kind of believe in the people that are doing the triaging. But actually, as we've gone on, more and more local consultants have actually taken shifts for me on the central virtual triage team. So now, Blackpool's consultant wanted to re-triage everything that came in and see if they agreed with the central virtual triage decision. But now their lead nurse is doing a lot of my central virtual triage decisions. That seems to have gone away. And I feel like that development will kind of come as we get that trust in that central virtual triage team. But it's the first of its kind. It exists in staffs, I think, in routine. I think it's staffs. But not for cancer, so... Oh, thanks. Thank you very much.
Thank you very much. I think that's it. Thank you.
Yeah, perfect, thanks.